We're doing a talk today on beating the winter blues, and I think everybody needs that. But it was great to put these on and walk through the hallway because people just started to smile as soon as they saw me. So how can you not with this on my head? But we've got a nice lecture, actually more than just a lecture, because we're going to do some cool activities as well today. But I'm Bernadette Melnyk. I'm Dean of the College of Nursing and the university's Chief Wellness Officer. And I'd like to introduce Megan and Maya. And Megan works hand in hand with me. She's Director of Health Promotion. So we are working very closely together along with a great team of people from across the university to really improve the health and wellness of faculty, staff, and students. We have occurring in faculty, in staff, as well as in students. So we're going to describe how the blues really differs from clinical depression. I'm going to talk about the prevalence, the symptoms, and cause of mood disorders. I'll talk about evidence-based interventions that have been supported to deal with depression and other mood disorders, and helpful tips and resources for that. So I want you to watch this clip first, because as Mariana said, often we can't change the events around us, the people around us, and how they act toward us, but we can change our thinking and how we respond to people and events. Just to set this clip up, there's this little boy, and he's got a big dream. And his dream is to be a professional baseball player. So he dresses up in a uniform and he goes out every day to the nearby baseball field to practice because he wants to be the best baseball hitter in the whole wide world. Well, look what happens during the course of one day's practice. Okay, Megan. I'm going to call for Megan. Ah, got it.
Strike three. Wow. I'm the greatest pitcher in the world. Yes. Optimism. Pass it on. A message from the Foundation for a Better Life.
So I really, really love that clip because this is obviously a very resilient little boy. Now, think about everything you might have been through in your life. Some of you, I'm sure, have experienced depression at times. Maybe some of you had a terrible trauma happen to you somewhere in the course of your life's trajectory. What separates, there's been a lot of research done on what separates people who experience trauma like that and yet grow up to be mentally healthy. A lot of it is based in resilience, that there's this resilience, a sense of optimism despite what we've been through. And sometimes it's so easy if you're surrounded by people who tend to think more negatively, talk more negatively, it's easy to fall into that trap. It's like I've always told my daughters, you end up becoming who you associate with. So if you have a group of folks around you who you are really negative and you're finding that it's tough to deal with that on a day-to-day basis. Change isn't easy, but I would say if you aren't successful at letting that negative clatter go on back here and not affect you, then it's maybe time to make a turn, make a difference, get out and do something a little bit different. Change is tough. It's what I call character building. So you see, instead of having a bad day, I have character building days. And that just helps to build the resiliency around what we face every day. So when we say people have the blues, all of us get the blues, right? We get into days or times when we do feel blue. It's hard to get up in the morning here when it's so dark in the morning. You know, in Arizona, where I lived before I came here, it was always sunny in the morning when I woke up. Here, not a lot of days are really sunny. So again, we've got to do things to get our brain thinking in a positive way first thing when we get up in the morning. But the difference between the blues and actual depression, the blues passes pretty easy in a couple of days. Depression hangs on, and it tends to interfere with our daily activities. It interferes with our ability to concentrate, to be really functional. So that's the difference. Everybody's going to have blues, and that's normal. You're healthy if you have the blues. But if those blues persist for a period of 2 weeks, then we're talking about something a little bit different. Then we're getting more into a depressive type of condition. What I want you to hear, though, is most people with depression get better. There is good treatment for depression, but it's super important to get it treated early, because if you have an episode of depression, you have a 60 to 70% chance of that recurring at some point. And the longer you let it go, the more chance you're going to get into of recurrence. So the bottom line is, there's hope. There's a lot of great treatment for depression, and it's nothing to be ashamed of. It saddens me so bad when I talk to our college students and they are struggling with depression, but they say, Bern, I can't go see anybody. There's so much stigma yet about depression. They're going to label me. You know, I have a mental problem. So we have a lot of stigma to overcome in terms of mental health disorders, including depression. So mood disorders are unpleasant moods that we have that are sustained for most of the day, and they are persistent. So unlike the blues, these moods persist. They don't go away very easily, and they do interfere with our functioning. And there are 3 types of mood disorders. We have major depression, which I'll talk about in a minute. We have dysthymia, which is less on the scale of severity of symptoms, but they last a long time. And then lastly, we have bipolar disorder, which all of you know is being diagnosed so much nowadays. So we have the prevalence of bipolar disorder really increasing, but I want to emphasize too, we have good evidence-based treatments if people can come to terms with, I do have this condition going on, I'm going to monitor my symptoms, and I'm going to get some help, because there is good help and treatment. So for adults with depression, we go through, those people who are depressed, you go through sadness, irritability. There's a lot of people, when they're depressed, they get irritable and they get angry. And this happens a little bit more in males than it does in females, but it still happens in females. So I'm a psychiatric nurse practitioner. My specialty is adolescence. And I can't tell you how often in adolescence, parents will fend off depression and say, no, that's typical normal adolescent mood swings. That's very common. Or my teen has a conduct disorder because they have a lot of angry outbursts all the time. When a person's angry a lot or they're irritable a lot, you have to always be thinking, could they underlying be depressed, or could they have some type of anxiety disorder going on? So that's one of the always rule-outs that we as psychiatric mental health nurse practitioners make when we see people and we're looking at potential depression. Hopelessness is the #1 predictor of suicide. So if you have a colleague and they start talking about, and they've looked depressed, they're withdrawn, they're sad, those sorts of things, and somebody said, there's absolutely no hope for my future. Red flags really need to go up. And if there's this other misperception out there, if somebody says they want to die or they want to hurt themselves, oh, those are the people that never do it. That couldn't be more off base. If anybody ever talks about, you know, there's no hope for the future, or I don't want to live any longer, or whatever it is, you've got to take that seriously and get that person help. Suicide is the 3rd leading cause of death in adolescents and college-age youth. So we have that happen here at the university. So again, how can we get into prevention? How can we build in mindfulness and physical activity and laughing into our everyday to help people build their resiliency so they don't develop these types of conditions? About 60% of the time when somebody is depressed, they also have a co-occurring other type of mental health disorder. And a lot of the times that is anxiety. So depression and anxiety often run together like this. But the good news about that, the treatment for depression and anxiety disorder is cognitive behavior therapy. So if you have somebody with both of those conditions, cognitive behavior therapy is a great evidence-based treatment for them. But fortunately, very few people who are depressed or who have anxiety disorder actually receive cognitive behavior therapy. In primary care, what do you get if you go to your primary care provider and they assess you as depressed or anxiety disorder? You get a pill. Because it's easy to write a prescription, here you go, you get a pill, and pills only work for 1/3 of the people who are depressed. So if you're depressed, you need to seek out somebody who does cognitive behavior therapy or cognitive behavior skills building like we offer in our college, because we know that's a great evidence-based treatment. So here's 2 screening questions that are recommended by the United States Preventive Services Task Force. So that's the group of 16 scientists, and I had the pleasure of serving on that task force for 4 years, who establish all the evidence-based recommendations for screening and behavioral counseling in primary care. In the United States Preventive Services Task Force guideline says all children between 12 to 18 years of age, all adults should be screened for depression routinely in primary care, but here's the second part of the guideline. When systems are in place for accurate diagnosis and treatment. So when I go out and do mental health workshops with physicians and nurse practitioners, and I ask them, how many of you routinely screen for depression in your primary care practice? How many hands do you think go up? Very few. And they say, we know this is the evidence-based recommendation. We know that, but we don't have systems in place to accurately diagnose and treat because we don't have enough mental health providers out there. So a lot of people are getting away with not implementing this screening because they say, well, we don't have the systems in place to deal with that. And it's a shame because if we could pick it up earlier and get people the cognitive behavior therapy or skills building they need, maybe we could avert a major depressive episode. But that doesn't happen. How many of you in the past year when you saw your primary care nurse practitioner or physician answered these screening questions? Or filled out the PHQ-9, we call it, the Patient Health Questionnaire 9 for depression? How many hands go up? There were like 2 hands that went up. So again, you see this isn't happening in primary care to the extent that it needs to be happening. The World Health Organization has said by 2020, depression will be the second most impairing disease worldwide. Depression. And then, how many people who have chronic illness also have comorbid depression? And if you don't treat the depression, what's the chance do you think you'll have of getting them to adhere to what you're prescribing and asking them to do? So this mental health piece, even for healthy lifestyle intervention programs, is really important. Because if we don't affect how people think, we're not going to have them feeling better, and they're not going to behave in healthy ways. So I'm not going to read this to you, but in order to diagnose depression, anxiety, bipolar disorder, practitioners follow the DSM-4, which is the psychiatric manual for diagnosis of mental health disorders. And the DSM-5 is going to be released in May. So there'll be some changes in the criteria. But what you have to remember here, we are looking for 5 of these particular symptoms to make the diagnosis of depression. And the first 2, depressed or irritable mood and anhedonia, that's a loss of interest in pleasurable activities, are very 2 key symptoms that really do affect a lot of people with depression. And again, you have to see this in the same 2-week period. So there's got to be these 5 symptoms that have been going on for a 2-week period of time. Now look at the difference between major depressive disorder and dysthymia. Dysthymia is not as severe in appearance as major depression, but it's still an issue because it does interfere with people's functioning, whether it's their concentration, their ability to do whatever it is they do every day to their optimal level. For adults, these symptoms need to be present for a year to make this diagnosis, or kids a year. Adults, kids a year, adults for 2. So again, it's this pattern, chronicity of these particular symptoms. And then we get into this. So I saw one of our medical colleagues at the place where I work out. And he was going on and on to me about, in the wintertime, he works out twice a day. Not just once a day, but twice a day, because he said, I have seasonal affective disorder. I am really affected by all these clouds during the winter. So again, if you tend to be affected in that way with seasonal affective disorder, what can you do to help yourself get through that? And I will tell you, just a little bit of physical activity every day, just some laughter every day, some reading in a positive book when you get up in the morning. If you maybe have to get light therapy on you because you're in a dark office, that's not going to help either. So, but recognize this affects many people and prevent it by making one healthy lifestyle change at the beginning of that winter time when you know you're going to get into a real funk with seasonal affective disorder. Depression is very prevalent. Very, very prevalent. I put the statistics for you up there in children, adolescents, and adults. And what's so sad about depression is less than 25% of people who have depression or dysthymia actually receive any treatment whatsoever at all. So they suffer with it for multiple months, and the average depression episode lasts from like 7 to 9 months, but that's a lot of time to have that be affecting you and your functioning. The recurrence rate is 60 to 70%, and that's why if we can catch people who have subclinical signs of depression and get them help then, all the better. Because this recurrence rate, once you do have a major depressive episode, is very, very high. Depression also comes before substance use about 4 years. And you see that so often with people using substances, whether it's alcohol or other types of drugs. A lot of times people are self-medicating because they aren't successful in other types of strategies, so they begin to use alcohol or drugs because it makes them feel better. So anytime I evaluate anybody who comes in, parent brings in their adolescents telling me this one's having a problem with drugs or alcohol, you know what I'm doing? I'm ruling out underlying depression and anxiety disorder because that often fuels that to occur later. There's multiple causes of depression. Why don't you think drugs, SSRIs, work for everybody? Why don't you think? Well, it's because you have multiple causes of depression, right? So you have imbalances in the brain, in serotonin, in cortisol. If you are a person who is depressed because you have chemical imbalance within your brain, SSRIs are likely to work. But if you are a person who has depression because somebody close to you just died, or because you tend to be a negative type of thinker, then SSRIs probably aren't going to help you. Remember, medication only helps about 1/3 of the people affected by depression. And then we've got to roll out physical causes of depression. Some people are anemic or hypothyroid, and they don't know it, so they're experiencing symptoms of depression, but it's not your typical etiology of depression. It's a physical cause of depression. So whenever I evaluate anybody for depression, I always want to rule out physical causes of depression before I absolutely confirm that that is what is happening. So management of depression and other mood disorders, psychoeducation is really important. A lot of people have trouble facing the fact that they do have some type of mental health disorder. So again, helping them face it, that this is what you have, but guess what? There's hope. and we can treat this. I never let anybody leave my visit without giving them hope that this is treatable and we can get through it and you can feel better again. Healthy lifestyles is really important. Psychotherapy is critical, particularly cognitive behavior therapy. So we have a program in our college that's a 7-session brief cognitive behavior skills building program. And we now are offering it every semester to groups of students who are interested in gaining these skills. So even if you don't feel like you're depressed right now, but you're stressed and you're anxious, you could really benefit from that. Caroline Graham is our mental health counselor here in our college. So Caroline, put up your hand. So you're going to be starting a COPE, Cognitive Behavior Skills Building group for students. When will that be?
The first Wednesday in February it will start.
The first Wednesday in February, it'll start for 7 sessions. So if you know folks, those of you who are students in the room, if you know folks who could benefit from this or you could benefit from it, I'd highly encourage you to get a hold of Caroline about participating in that particular group. We have an online format of this too that we have developed for Ohio State students, and 5 colleges throughout the university actually incorporated this 7-session cognitive behavior skills building program into their required freshman survey course this semester. And we did it as a pilot study, and we're in the process now of analyzing these particular results. My hope is to bring that program to all freshmen when they come into Ohio State, to really equip them with skills that will really help them with stress, with anxiety, and with depressive symptoms. Cognitive behavior therapy and theory really emphasizes that how you think directly relates to how you feel and how you behave. So we teach the ABCs in cognitive behavior therapy. A is an antecedent event that triggers a negative belief. Did any of you have a negative event that happened today that you're willing to share? What happened?
Oh, I had a colleague say that they had changed their mind about a decision that they had agreed upon previously.
Ah, so a colleague changed their mind when you really were counting on that colleague to whatever it is. So what was the belief that followed? What's the first thing that you thought after that happened?
I was frustrated and thought, oh, we wasted all that time last week, and this person's never gonna.
Yeah, this person's never gonna change. Whatever it is, right? So what we teach people in cognitive behavior therapy or skills building is to catch themselves before they think that thought, okay, which is a more negative belief, and turn that around to something more positively so we feel better, right? And we act in more positive ways. So that's the ABCs that we teach people in cognitive behavior therapy. What I want to emphasize about medication, the selective serotonin reuptake inhibitor. So if you do have a chemical imbalance in the brain, say you don't have enough serotonin there, these medications block the uptake of that serotonin, so you have more of that circulating in your brain. Now the problem when people are prescribed in SSRI, a lot of times they don't get appropriate counseling to go along with that. A lot of times they're not told. Sometimes it takes 6-8 weeks before you really begin to see an effect on this medication. So what do you think happens? A lot of people discontinue it, in week 2, in week 3. So these need to be used too for a first episode of depression for 6 to 9 months, because we want to make sure that recurrence does not occur. These are common side effects of the SSRI. Serotonin syndrome could occur as well, but that's very rare. But a lot of people discontinue these medications because they're experiencing these types of side effects. And always, if you have a colleague who you see, if you have a student, friend, who you see as depressed, we've always got to ask about suicidal thought. And we always need to take it seriously. The worst thing in the whole wide world, I can't tell you how many parents that I have counseled over the course of my career who has lost a child due to suicide. And they beat themselves up for many, many years to come because they didn't pick it up. They have the survival guilt. They didn't recognize it and do something about it. So you never want to be in that particular position. So lastly, tips for beating the blues. We have evidence behind this. Physical activity releases endorphins. They help you to feel better. Do a little physical activity every single day. Sit less. Stand up more. Stretch more. Don't schedule 1-hour meetings anymore. Schedule 50-minute meetings, and then for 10 minutes, it's recovery time. So we have a program that we have been offering here at the university. It's called Health Athlete. And we just did an orientation program for 105 wellness innovators throughout the university on Monday. And those folks are going to go through the program. The Health Athlete program teaches you about how to manage your energy better. See, everybody nowadays is trying to figure out, how do I manage my time better? I talk to students about this all the time. Bern, give me better time management strategies. And I always say, we're not going to talk about time management. We're going to talk about energy management, how to keep your energy up all day so you don't go crash and burn after lunch or at certain peaks during the day. And it's related to how we eat, and it's also related to, are we getting recovery breaks? Going for a 5 or 10-minute walk. I have walking treadmills on the 3rd floor up here for faculty and staff. I put in an exercise room on the bottom floor here. You'll see a mini elliptical in my office, because even if it's 5 minutes and I get on the elliptical, my mind's so much more alert when I get done. So if you can find ways to build in just a little bit of physical activity sporadically throughout the day, you're going to feel a lot better. Break your routine if you're rutted. Do you know how many clinicians we have practicing all throughout the United States and healthcare systems that are practicing rutted and roaded? Like, do you ever drive home some days and you don't know how you got there? You know, went through stoplights or whatever it was? Well, a lot of people are working their jobs that way. Really super rutted. And a lot of people have lost their passion. They've kind of buried their dreams. And I'm here today to say, get dreaming again. Get connected with your passions again. Because if you're connected with your passions and you're dreaming again, you're going to be excited about getting up every day and doing what you do. Stay in the present moment. That mindfulness exercise we did. How many of you, and you can admit this, how many of you, when you were doing that exercise, were thinking about what you had to do the next hour? Some of you were. You know what I mean? You got to train yourself to live in the present moment. And if you have not read the book called The Present by Spencer Johnson, I really encourage you to get that book. It's an easy read. It'll take you an hour and a half to get through. There's a picture of a present on the front cover, and it's not about a physical gift at all. It's a story about a little boy meeting a wise elder man, and the older man talking about the best gift in the whole world is this present. And this little boy goes off on a journey all his life to find this physical present. And then he realizes that's not it at all. It's the beauty of staying in the present moment. The two most wasted emotions that we as humans have is worry about what's to come, because 95% of what we worry about never happens, or it's guilt for what we didn't or we did do in the past. And I was raised Catholic, so I know what that guilt is all about. I feel guilty about everything. My best friends always say, I love the fact that you're Catholic, because I get you to do anything with guilt. Get enough sleep. How many of you get 7 hours of sleep a night? 7 or more. If you don't, I highly encourage you to start upping that amount of sleep. We know people who sleep 7 hours a night or more have less cardiovascular problems, have less depression, because they don't have as much cortisol being released. So there's a lot of science behind 7 hours of sleep a night. Balance work, and I work on this all the time. Our faculty know that. I'm not the best in terms, because I love my work. I'm passionate about it. But a lot of times I go too far, and then my personal life suffers for it, or my family's life suffers for it. But we can do more balance. I'm getting better at balance. We have email holidays here in this college now. So once a month, in fact, next weekend it's a holiday. It's going to be email holiday, because emails are killing us. And they're stressing us out because we're getting bombarded and we just can't keep up. So we got to develop strategies for that. Vitamin D. How many of you have had a vitamin D level checked recently? Were you normal or low, can I ask?
I'm very low.
See, low. Believe it or not, before I left Arizona, I had a vitamin D. I'm like to my provider, you don't need to check that. I love the sun. I'm out all the time. No, we're going to check it, Bern. My vitamin D level was terribly low. So if you have not had a vitamin D level checked, next time you go to your provider, ask for a vitamin D level. It is being linked to so many things now. Depression, overweight, obesity. So if you haven't had that done, do get it done. I take vitamin D every day now. Have an attitude of gratitude. You know, for when people are really depressed, I'll say to them, let's form a list of some things you can be grateful about. They'll say, I have nothing to be grateful. I've worked with people. I have nothing to be grateful about. Well, let's think about that. Do you have kids? Yeah, I have kids. Are they healthy? Oh, that's something to be real grateful about. You know, you have 2 arms, 2 legs. Yeah, you can walk. That's something to be real grateful about. Did you see that special the other day that they had on? This guy from Australia was born with no arms and no legs. And this guy is running around everywhere and motivating people about how great life is and what you can do no matter what your handicap is. So if we get up every day and, like I do, read 10 minutes in a positive book, because it's so easy to come to work and you hear, we can't do that. This is too hard. This isn't going to work. And you get bombarded with that, you start feeling blue right by the end of the day. So you have to put on a shield so you don't get so bogged down in that. And my way of doing that, get up in the morning, cup of coffee, read 10 minutes in a positive book, because it buffers me against the negativity that often bombards us during the day. Laugh more often. See the cup half full instead of half empty. Know when to say no. My classmates used to tell me in my PhD program, you should have a button that says, my lips say yes, but I really mean no. Because those of you that are overachievers, that you just get excited and you want to do everything, you often tend to over say yes to things. And then you're built up this high in your priorities on your plate. And then you get stressed out as a result of that. So now, you know, Kathy, my wonderful support, the wind beneath my wings, she'll say, now Bern, do you really want to say yes to this? You know, so we have a mechanism in place. And I'm getting better, right, Kath, at saying no at times. So the last thing I'm going to show you is, first I'm going to say, if I could be your fairy godmother today, and I could give you any dream or wish that you could achieve in the next 3, 5, 7 years, what would you do if you absolutely know you can't fail? What would you do? It's interesting. I ask faculty candidates coming in that question. Do you realize 9 out of 10 people I ask that question say, I haven't even thought about that in years. We've lost our ability to dream. And when we lose our ability to dream, we disconnect from our passions. And then things become rutted, you know, rote. We get up every day and we do the same thing because we don't have the dream in front of us anymore. And you cannot let, you know, my students used to call these folks, the negative folks around us, negatoids. You know, they said, Bern, these are negatoids. It's okay, because we're going to have our shields on, and we're going to continue to be positive and dream and believe and move forward. So I want to end this talk with saying, get connected, start dreaming again. People that dream more are excited about every day. They don't tend to get as down. Great. So dream big, believe in those dreams, commit to doing something in the next 90 days. Just commit to doing something that'll be positive for your mood state. And get a buddy to help you with that, whoever that is. And dream big and believe and exercise and do these positive things to keep the winter blues away. And we'll do something in the spring focused on happiness and fun or whatever it is. So thanks for coming today.